What I see people get into trouble with strength building in particular is a couple of things. Number one is overemphasis on pushing exercises, and that is coupled with our posture, sitting at the desk a lot more, and people tend to get very tight in the front.
So let's dive right in. Dr. Patrick Denard, who, as you know, did some phenomenal surgery with my mom, Joan MacDonald, back in September. And I was just saying to him offline that it was so wonderful to see my mom being able to, without pain, raise her arm above her head and even train. She just did some incline chest presses, and it was a joy to see her having fun again, training her upper body. So the purpose of this particular episode is to really get as much information out there to you guys on how to take care of your shoulders as you pursue gaining muscle and gaining strength and being strong, right? We want to be strong. We want to be able to train as long as possible. We now know how important it is for a woman to build muscle. So without further ado, let's go in. Dr. Denard, why do women break their shoulders without knowing it? What mistakes do you see every week? And I just saw you post on the gram, and you said it went viral, or it just really blew up. What are women doing in the gym right now that make you quietly wince as a surgeon?
You know, honestly, Michelle, the biggest thing for me is them not getting in, right? So that Instagram thing was more about just trying to be careful with some of the overhead stuff. But the thing I see day in and day out as an orthopedic surgeon is women not getting into the gym. And I love that you're advocating for this because, as you know and have shared with your audience, building muscle is so hugely important. And we always thought just men, but, it's very vital for women across both men and women. You have reduction in mortality. Large studies show that. You obviously have reduction in chance of fracture, which is huge. So for me, it's really about trying to encourage people to be as active as possible to really maintain their quality of life.
Yeah, it's funny. Mom actually needs a knee surgery, and we're plotting to shoehorn that in maybe in the spring. And the surgeon that we're taking her to, I asked him, how quickly will she be able to return to training? And he was taken aback. He said, I love that you asked that. And he said, and I wish everybody, especially people my mom's age, she's 79, she's almost 80, I wish they asked that question. He said, most of the time I am trying to encourage them to get into the gym and train as part of their rehab. Do you find that as well?
Yeah, absolutely. I mean, you find just from, how it's been for years that women are coming in their 60s, 70s, 80s, and they really haven't done any of this muscle training at all. And we know, as I'm sure you've shared, you lose about 1% bone density per year after menopause. In particular, it goes down. And maintaining muscle is vital to offsetting this, right? So, I wish more women were doing that. I think that's starting to shift a bit, things like the efforts you're doing, and we're seeing more and more about protein and even creatine, which we can certainly talk about, I think are really helping change quality of life. And we're learning people are seeing you can do that even later in your life, as your mom's an awesome example of, right?
Yeah, you can start later.
So it's never too, you want to start early, but it's never too late, I think.
Yeah, I think that's the message we've all got to keep hammering home. Just with lifestyle levers, you can just massively turn yourself in a different direction and in a relatively short period of time, because you want to zoom out and look at perspective, and even 5 or 6 months of dedicated effort, you can really change your ground zero. However, I coach women. I've been coaching women since 2012, and I think what I see the most coming out recurrently for my clients are issues around tendinitises, impingement starting to happen. I've always corrected women for their form simply because especially something like the shoulders in physique sports, having a beautiful shoulder cap is important. But if you don't do it right, you end up having these really overdeveloped upper traps and actually more shoulder rounding and challenges building at the rear delt. So that I've always been interested in that, but now that my clients have aged with me, I'm 55 and my clients have really aged with me, and I have a lot more clients in their 60s, the impact, the negative downstream effects of not having great shoulder mechanics, especially shoulder blade gliding, proper, sequencing, what muscles are activating first in order to have that great healthy shoulder placement, and so that upper arm bone, the humerus, is moving appropriately inside the shoulder socket. I'd love for you to talk more about that. Like what do you see patterns? What fails first in women's shoulders? I mean, this could be men and women, but I think most of my audience are females. What fails first in women's shoulders and why? Can you talk about that?
Yeah, I mean, one thing is just rotator cuff tears. When we talk about the spectrum of tendonitis, impingement, rotator cuff tears, that's all along the same spectrum, right? And I think it's important for people to know that some of this is, or a lot of this is age-related and genetic. So 50% of all people by age 65 will have a full-thickness rotator cuff tear.
Say that again. That's huge. 50%.
Yeah, 50%. 50% by age 65 will have a full-thickness rotator cuff tear.
What is that?
Now, the good
that sounds
news,
scary.
So rotator cuff, you have 4 muscle tendons that surround the ball and socket to keep your shoulder stable. Primary function of the rotator cuff is to keep the stability of the shoulder and help you rotate and lift, essentially. So you have 1 in the front, subscapularis, supraspinatus on top, 2 in the back, infraspinatus and teres minor. And most commonly, the supraspinatus tendon tears. A lot of people think it has to do with just an injury, or they assume that something had to happen, but that's not the case. And most of it it will happen from degeneration over time. Now, the good news about that is that means a lot of people are not aware of this tear. In other words, it means that you can get by without having a rotator cuff tear. We can get a treatment, et cetera, if we want, but your body essentially has backup mechanisms, and the best thing you can do is maintain your strength overall to prevent this from becoming a symptomatic problem, right? So, I mean, we're talking about strength building, of course. What I see people get into trouble with strength building in particular is a couple of things. Number one is overemphasis on pushing exercises, and that is coupled with our posture, sitting at the desk a lot more, and people tend to get very tight in the front. And what happens there is their pec minor especially will get very tight, and they typically will get some symptoms in the back of their shoulder blade, get abnormal shoulder blade mechanics or scapular mechanics, as you alluded to. So I really encourage my patients to be doing a lot of stretching in advance as part of their warm-up, doing a lot of door frame stretches against a wall, getting their hand, wrist, and elbow, to turn away, and to really be emphasizing their scapular mechanics by strengthening. So that's the biggest thing I see. The other thing that we can see at times is it's not necessarily in the population over the age of 50, but you get in that kind of mid-age population, that 30 to 50, if they're doing a lot of explosive exercises in an unregulated manner, especially when CrossFit was a craze. I myself was a CrossFit person, but I saw a lot of people in that category, get rotator cuff injuries at an earlier age that you would expect from doing kipping pull-ups, snatches. Not that you can't do those things, but doing those in a, probably not the best form kind of technique that would put unnecessary force on the rotator cuff.
So let's dial that back. So you're saying the most common injury is supraspinatus?
Yep. Rotator cuff tears are the most common thing I see. Rotator cuff far and away, and then second after that is arthritis. But rotator cuff is the most common.
And that can happen.
That is what.
That can happen without an injury, without anything acute happening. It can, and I almost want to think it's almost more likely that it's this accumulation of the death by 1,000 cuts, right? Posture, work environment, and then when we start loading and doing things like the pressing, especially overhead pressing, without those good mechanics and having all the postural issues, tightness, you can really create some unnecessary friction pretty quickly. Did I get that right for the listeners?
I think that's fair to say. I think the other factor that we really can't control for is tendon degeneration that just happens as the process of time, right? Yeah. And, I tell people all the time, if I just go to the store and say, line up 100 people and ultrasound them, half of them are going to have a rotator cuff tear over the age of 65.
So can you talk a little bit more about what you would recommend beyond just some stretching, like your top favorite, like maybe number one, how would you have somebody even look at their scapular gliding? Do you have them, videotape their back with like a racer back tank? Sometimes I do that with my clients. Like I said to one client just now, I want you to do a shoulder press with a racer back tank so I can see your shoulder blades. I want to see what's happening back there. Can you talk a little bit about that for people?
That's great. No, I've never thought about doing that. We typically are doing it in conjunction with a physical therapist, right? Who's going to give somebody some feedback and be able to look at their scapular mechanics after I make an assessment. But the real key again is stretching in the front, making sure you're not too tight. And then I love exercises that really work on scapular strengthening. So the primary exercises I recommend are simply external rotation at the side with bands. You're going to be strengthening the posterior rotator cuff. Rows, which are obviously going to help strengthen the muscles around the shoulder blade, and then internal rotation as well. And I do recommend some abduction exercises in the scapular plane. I just think that you should do those with light weight. If somebody is really struggling with scapular mechanics, sometimes that tightness in the pec minor is hard to overcome. So there are certain exercises that can be done that are going to inhibit the pec minor, because what happens with the pec is it wants to pull the shoulder blades forward, and you get this protraction, or as you kind of alluded to, kind of slump forward shoulders. So a really good exercise for that is to have somebody do a lawnmower where they're kind of bent over, a little bit hard to demonstrate here, but they're bent over on the opposite side and coming back. And by leaning over, the pec minor is not as active. Another one is simply leaning forward in a Superman position and just taking a very light weight, say 1 to 2 pounds, and doing sort of YWs as they're prone or laying face down. And that, again, the pec won't be as active. It will allow them to control the scapula and help a scapular retraction.
Beautiful. So you're taking that pec out of, I guess, is the plane of gravity, so it's not getting triggered to work. Is that what's happening?
Exactly. Okay. That's fair. That's a good way to put it.
So then another thing I want to ask you. So we've got this idea of the pec minor, right, being tight, and then also just activating when we don't want it to and pulling us out of that good alignment. What about, do you want to speak a little bit about the upper trap, lower trap coordination? Because that's something that I keep seeing. I actually zoom in. My gals send me videos. I zoom in, and I probably spend a good amount of time every day looking at what's initiating. And every time I see that just the shoulder popping up, I'm like, oh, okay. Because I want them to go to failure and I want them to get strong. So I've got to really make sure that they have the fundamental movement pattern right. So it's that upper trap, lower trap coordination. Why is it so hard? Why is the correct movement so unnatural? It's the irony of life.
Yeah. Well, I think that probably just comes down to how we spend so much of our life, right? Michelle, just, kind of hunched over. The tendency is everybody slouches, and again, we're spending a lot of time at our desk, and so we're, not activating on a continual basis. So it's, and when we're training, I think it's really important to, really emphasize control of the scapula. It's amazing in clinic, for instance, when I just demonstrate a simple exercise like scapular retraction, how many people struggle with the ability to get the idea of just pinching something between their shoulder blades because they're just not used to doing it. So I don't know how well you can, I think it's, distinguishing trap versus those. I think it can be a little bit hard. I think about for people just trying to control the position of the scapula, think about being able to engage and pull back. set their scapula before they're doing exercise to put them in a stable position for the most part.
Yeah. Yeah. I think also as an online coach, I will put gals against a wall, so their scapula on a wall, somehow being able to have some proprioception.
Get some feedback.
A little bit of feedback so they can feel what's going on, or I'll do them one arm work, right? If I see that there's a lot of issues and the upper traps are just, they're on their own, right? They're like, I'm doing everything myself. I say, just do one arm, put the other arm here, and just try to move without them gauging. But it is a challenge. And then of course, trying to get them to see a physio can be very challenging, especially depending on the country they're in or where they're living, if they have access to a really talented physiotherapist that also believes in my avatar, right? Like, I hate it when I send somebody to tell somebody, go see a physio, and they come back and they say, well, the physio said don't do anything. And I think, oh God, that is not helpful at all. Could you please help me be part of my team here?
Yeah. Yeah.
So that brings me to the next question. How can women give us your insight? How do women recognize issues before they're forced to stop training? Do you have some hard stops or some flags that women listening can kind of sober up and listen to this? Because I spend a lot of time saying, we're older, we have to really drill down on what we can do and what we can't do, and we got to be smart about catching things early on and shifting behavior, and really, don't push through inflammation, don't push through poor mechanics.
Right. Yeah. Well, I think a couple of things there. I mean, one is timeline, right? If somebody's having symptoms for more than 6 weeks and they're, doing things like a little bit of rest and anti-inflammatories and watching their training, that's not doing anything for them, it's probably time to take a look and just make sure they're not ignoring something. One thing that I commonly see, especially in the 40 to 60 range, sometimes between the 60 and 70 range, but most commonly 40 to 60 range, is frozen shoulder, especially in women, where you lose range of motion of the shoulder due to capsulitis, where the capsule, which is the closest layer of the shoulder, gets really inflamed. Most cases are idiopathic, meaning we don't know the cause. There is association with diabetes, but you don't have to have diabetes to get it. But what I will see in that case is people will lose range of motion, and then they will get misdiagnosed, and they'll be told to just keep doing strengthening and keep working on strengthening, and they're not getting anywhere. So I think, what I'm trying to say there is with that one is basically watching where your range of motion is. And if if you have full range of motion, okay. But if you're losing range of motion, that's one where I would really be focused on stretching alone. And if it continues to go on, get an evaluation in that case. What else in terms of, strength loss? If people are having strength in abduction, especially, out here to the side, that's continuing to persist, that's one that you would want to look for potential for rotator cuff tear. Again, most people are going to respond to physical therapy for rotator cuff tears about 70% of the time.
70% of the time they're going to respond to, right, okay. Good to know.
Yeah, if you look at rotator cuff tears, it's really an age decision, activity decision. The data says 70% of people get better with physical therapy. But rotator cuff tears don't heal themselves. They stay the same size or get larger over time. So if somebody doesn't get a quick response to physical therapy, which tends to be 6 weeks of that based on the evidence, they probably want to look at further treatment or evaluation with an orthopedic surgeon, because if you get to those tears when they are small, you can prevent those from getting larger over time. And when you compare the long-term outcomes of surgery versus therapy, those with surgery are better because you can fix the tendon. So there's a lot there. But bottom line, if somebody's having, strength loss with overhead, I think that's a good reason to get an evaluation for their shoulder.
Great. So for you, that the delineating factor is strength loss with overhead and strength lateral, or just overhead?
Overhead is the most common. It's going to be right here in, abduction, anything overhead. If they're having strength loss or motion loss, those are the two big keys that I would be stopping and looking at further. I think you've hit the other things, just listening to your body and and not letting things kind of get ahead of themselves in terms of, or continue down this cascade of inflammation, right? There's definitely a lot there as well. But if it's persisting and you're having those two things, I think that's really where it's time to take a peek.
And then you're saying 6 to 8 weeks of physiotherapy. We're looking at, what was the percentage? Is it 70% or 65%?
Yeah, there was a large study in the United States of several hundred patients. I believe it may have even been 1,000, where they followed people who had physical therapy. In that study, they did therapy for 6 weeks. And that 6 weeks of therapy was considered successful in 70% of people, meaning that they did not go on to surgery, and they didn't go on to surgery at 2 years, and even at 10 years, they didn't go on to surgery. So even though the rotator cuff wasn't healing, you're rehabbing and having everything around compensate, they're having very good function long-term, right? Again, that doesn't mean that, surgery can do very well, but the vast majority of people get by without it.
Now, I'm going to ask that question. Were these people active, like weight training or playing sports, or was it your average?
They didn't define that. Yeah, they just took all comers in this study.
Right.
Everybody, it was over the age of 60.
Yeah. Oh, over the age of 60. Okay.
It is.
Well, how many people over the age of 60 are training? Not very many.
Sorry?
Now, how many people over the age of 60 are training? Not very many. We know, though, that's one of the reasons why sarcopenia is such an issue.
Yes.
So then another question that I have is around different types of surgery, if you could talk about that a little bit, right? Because you hear about laparoscopic surgeries, cleaning up the meniscus, getting in there early, fixing things before it becomes a bigger problem. Could you bring some light to that?
Yeah, sure. So there's the two main categories of things we take care of as I take care of as a shoulder specialist are rotator cuff tears and then arthritis, right? So rotator cuff tears, our goal there is arthroscopic. Arthro is joint, scopic is to look. So look inside the joint with a camera, repair the rotator cuff. And although we said that physical therapy is beneficial in the majority of cases, long-term data, 10-year data shows that actually surgery does better than therapy in terms of function. So when somebody is healthy and active and they have a full-thickness rotator cuff tear, fixing it can perhaps, or in most cases, give them a better outcome. And that basically involves putting a camera inside the shoulder, repairing the tendon down to the bone with anchors. I tell people anchors are like headless screws the size of a pen cap, like a drywall anchor, but they have sutures that allow us to attach the tendon. Because without therapy, the natural history is rotator cuff tears will progress. But if we fix it back down to the bone, we can get the tendon to heal. That can be done in a minimally invasive fashion. People go home the same day, very good results, low risk complication, 1 in 100, for instance. However, the recovery tends to be a long period of time. Typically, somebody's going to be in a sling for 4 to 6 weeks, depending on the size of the tear. And I tell people it's 6 months for full recovery. At 3 months, you're about 70% recovered. So it's one of these things where it's a case-by-case decision. You got to really look at the long term and how much their quality of life is affected. But you can do very, very well from rotator cuff tears. With arthritis, it's like your mom, it's a completely different scenario. There you have loss of the cartilage where you have breakdown of the joint and you lose range of motion, and that's where we're doing joint replacements. Just like somebody has a hip or a knee replacement, it's very similar. The fortunate thing there is that, there's very, very good outcomes with the technology that's now available, where if somebody goes on to shoulder replacement, 90% of the implants are still in 10 years later. 70 to 80% are in 20 years later, meaning people can live very active lives. We've done multiple studies looking at return to yoga, tennis, golf, et cetera, very high return rate to play. And interestingly enough, even though when you think about a rotator cuff repair being minimally invasive, even though a shoulder replacement requires an incision, actually people have a very, very fast recovery, because you take out arthritis and their quality of life is, almost, many people wake up and they just say the pain's gone. So
Can you explain that again for people listening? Because I think arthritis is a big thing. You take the arthritis out. Like, even to me, that sounds wild. How do you take arthritis out? Can you just break that down a little bit for us?
Yeah, I mean, crudely speaking, you go between the muscle plane, but very crudely speaking, I mean, you cut out the arthritis, and you pick implants that match the patient's size. And especially now, the vast majority of shoulder specialists like myself will be using planning software. They will look at everything in advance, have a really good idea of what they're going to do, what the pathology is, meaning the deformity of the bone that they're dealing with, and be able to address that in an efficient manner. So we're just removing the joint. Some people think we're taking everything out. We're just going between the muscle planes, removing the joint so that you have a smooth glide and you're removing the pain generators.
That is so wild. So it sounds like there's a little bit of a question mark. And please correct me if I'm wrong, because I want to make it really easy for people listening to understand.
Yeah.
It sounds like there could be a bit of a question mark around a rotator cuff tear, right? This is something that you could continue to have success with without a surgical intervention, and that's going to be case by case. I think you do want to be sure that you're not progressing the tear, because if a surgical intervention is on the table, you want to get in there a little bit earlier
before it gets too
later,
large. That's right.
Right? When it comes to arthritis, that's maybe a little bit of a different, So
the way I think about it for rotator cuff tears is a general guideline. If somebody's under the age of 60, let's just assume they're in average health or good health. Under the age of 60 and they have a full thickness rotator cuff tear, I would just repair it, because there's such a long time for that to get larger.
So under the age of 60.
Over 70, under the age of 60, yes.
60,
Over the age of 70, I always start with physical therapy first, because many of those people are going to do well. They may or may not be high demand, and the results are pretty good. If they don't respond, then surgery is an option. Between 60 and 70, for me, it's kind of a decision with the individual. How healthy are they? Are they a very, very active person? Well, we know if they're very, very active and they have a 20-year life expectancy, that's probably somebody we would have a discussion with fixing it. If they're very low demand, maybe unhealthy, in their mid-60s where they have multiple medical problems, we probably want to start conservative. So it's kind of a case-by-case, within that category. Arthritis, it kind of depends on the severity. I always tell people it really just comes down to quality of life, how much motion loss and how much pain they're having. Shoulder arthritis has a huge impact on quality of life. I mean, actually, we see that the impact is as large as having a chronic cardiac or heart condition. So it affects people in a lot of ways because they lose sleep. That affects, of course, your mood, your recovery, and all that can really lead to a downward spiral. So if we can't manage it with simple things like therapy, perhaps some injections as needed, then especially with more severe cases, that's where shoulder replacement can give a lot of relief.
I'm so glad you brought that up as well, because I wanted to talk about injections, right? Specifically cortisone. How many times can somebody get an injection before that starts to have negative outcomes?
Yeah, we've gotten a lot more conservative about injections over the years. I mean, years ago, people would just have injections almost every month. We know that if you do injections with steroid, the idea is that you're creating an anti-inflammatory effect, right? Because a steroid at a base level, that's what it does. However, there's also a catabolic effect, meaning that it breaks down tissue. So we tend to see that if you do injections over and over, that can have some negative consequence. We see that in a couple of ways. One is that if somebody has injection within 3 months prior to a surgery, we know that their risk of infection goes up, probably because you've put the tissues in a susceptible state. We also know that if you give 2 injections in the year prior to a rotator cuff repair, the chance of a revision surgery goes up. Again, probably because you've created some negative consequence in the tissue. So as a general rule, I will try to say no more than 3 injections in a 2-year period. Practically speaking, most people, after one or two, you're going to start to see diminishing returns. And at that point, we're going to move on. There's exceptions, if somebody's in their late 80s and they have health reasons where we can't undergo surgery and we're trying to get them a few months at a time, we'll bend that rule in their case. But for a healthy individual, I would try to, be very limited in my number of steroid injections. There are some alternatives. We've been doing more and more PRP injections, platelet-rich plasma.
I was going to ask about that next.
Yeah, so PRP, you take blood off your own body, you spin it down, you get the growth factor-rich area, inject it back into the site, whether that's in the joint or around the rotator cuff. It doesn't regenerate, okay? If somebody's saying it regenerates tissue, they're probably doing false advertising. It probably works through an anti-inflammatory effect. But we do see clinically that people can get benefit from that. There's actually pretty good studies in knee arthritis that shows benefit compared to some other things that are used for injections in the knee. And I've had a lot of success in using that with shoulder arthritis as well. If it's on the mild to moderate side, if it's severe bone on bone, you're probably not going to get a benefit. But if it's on the mild side, we see the majority of patients get at least some relief. That's safe. There's not thought to be long-term consequences.
Is the data clean for placebo?
Placebo?
Yeah, is the data clean for placebo?
Placebo is a powerful thing. I mean, I think about this all the time, show with stem cells, I mean...
I was going to ask about that next.
Yeah, I mean... Placebo effect is real.
Yeah.
And I mean, the power of having somebody go and undergo something, especially when they're paying a lot of money for it, and have them have in their mind that they're going to get a benefit, it is real. Studies suggest that the placebo effect is 30 to 40%.
I remember that knee surgery done, and it was Stanford, right? And a couple of decades ago, and it was pretty mind-blowing. Like fake surgery was as effective as the real thing, which is wild.
There's a study on knee arthritis with scoping knees, and they did scoping versus sham surgery. That may be the study you're referring to. It was done in Texas, I believe. And those who didn't have anything, just had the scope put in and that was it, had a benefit, so they had scars. And so you go, well, okay, scoping didn't do anything for them, cleaning things out. But on the other hand, I think that just shows how powerful the mind is, right? In terms of the ability for it is actually, it very is, because then it gets back to everything we're talking about taking care of yourself, right? Because we know on a physiological level, if you work out, you get release of all sorts of endorphins. It's the most powerful antidepressant we have, and you have people having a positive mindset. So all this stuff kind of goes together. And that's why as a surgeon, I'm interested in this. It's not just about surgery. It's about the mindset and about, the whole picture with nutrition, et cetera.
I think that leads me to the next, thing I want to talk about with you before we wrap up. And that's, what women actually need to know about about surgery. And I wish, people ask me about my mom's journey with her shoulder. I am very cut and dried. I wish that we had, number one, when she fell from a bike, she had some arthritis, yes, but she fell off her bike. She's a wild thing. She is a wild child. So she rides her bike like she's 10 years old, I swear to God, swings her leg up over while she's mid-pedaling and all that. Carefree. That's my mom. And she fell off her bike and hit this concrete thing. I think she broke the concrete thing because that's my mom. Wow. She is just so tough and strong. But we saw a physiotherapist. We did not get proper imaging. And she said, because she's tough, oh, I'm okay, I'm better. But I believe that from that point on is when the issues started to really evolve. But then we did some alternative therapies. We tried the stem cell and all that, and it really didn't get better. And she ended up being in quite a bit of pain like that last year before you saw her in September. She was in so much pain. And that does, as you said, it creates depression. And it's almost unnoticeable until you realize, mom's off. She's not her usual self, and you see her trying to, put her shirt on or something, and you realize this is acute pain and it's chronic. So, what predicts good versus surgical outcomes? And can we also just, again, the gals listening, a lot of them are older, damage has been done, they're trying to train through it. When should they see the surgeon? So we've talked about that a little bit. Why delaying isn't the right move? And then what can guarantee or what can increase the chances of a successful surgery?
Yeah. So I would just add one more thing. I think the other message in what you just said is that she fell and she didn't break anything. And probably it's, a lot of women have decreased bone density as they age. And because of her strength training, she maintained muscle that helped support her when she fell. She had good bone quality when she fell. So she didn't have a larger injury. So a lot of this working out is the insurance against everything in case you do run into these problems. When it comes to surgery, I think what I always love to see is somebody who has the right mindset, good nutrition, and a good surgeon. If you have those three things, you're going to be in a really good spot. So that is, of course, being optimistic about everything. Somebody who comes in having a training background, not only going to be better at a physiological spot, but they're going to be more sort of prepped or cooped to be able to go through a rehabilitation, which can be, substantial in itself. And then, of course, you want to get in the hands, if it does require that, of a specialist. That a lot data across all medical specialties shows that complications are lower and outcomes are better with somebody who does a lot of it. So I think, obviously I'm biased there as a shoulder specialist, but it's across all the boards. Aside from the prevention piece, again, if somebody is having symptoms for more than 6 weeks, especially with weakness or loss of motion, it probably makes sense to get an evaluation by somebody in that area who's a shoulder specialist, so that they can at least evaluate what their options are and see that they, if they have something and it might be something they can just manage conservatively, but it might be something they want to get to earlier to kind of maintain their health long term, along with all these other things we're trying to do to maintain our quality of life.
Can you speak a little bit about what kind of tests a woman can expect from a surgeon or a physio, whoever she's seeing to kind of diagnose her? Is this a pain that I can work around, or do I need to escalate this to a surgeon? What kind of tests or imaging should she be expecting? Like
things that people can do on their own, or you mean like in clinic if somebody has to get an evaluation?
Boy, I guess, you can do the whole gamut, right? I mean, what you can is self-assess, and then if you go to see somebody, what you should expect them to test for.
Yeah, self-assessment, you just, monitoring your range of motion. Really simple. A door frame is a great way to do that, and testing your, just monitoring your strength. Those are really good things that people can do on a simple basis, and just making sure they're integrating some scapula exercises on a regular basis into their workout routine. Even I like doing that just as part of a warm-up. When it comes to an evaluation, basically you should expect somebody that listens to you first off, understands your goals, where you're going to get back to, and understands, your symptoms. After that, we assess range of motion to see, what their function's like, their strength. And imaging-wise, then it's always X-rays followed by either an MRI and a CT scan. MRI is to look at soft tissue or rotator cuff. That's typically a path we go down if somebody's weak, especially if they haven't responded to therapy. CT scan is to look more at the bone in cases where there's arthritis that might need a replacement.
Beautiful. I like to ask this question from everybody. What are the top 3 things that you feel women listening to this should be doing, especially those in that 40-plus category, to preserve their shoulder health?
That's a great question.
This assumes that they're already training, they're at the gym and all that, they're eating their protein.
Yeah, I would put vitamin D on that. That is one of the things I would do, because there's such a relationship with vitamin D and rotator cuff tears. So people who are vitamin D deficient have a much higher risk of rotator cuff tears. So
Is that
I would
like
make sure.
an associated risk, or is it a causal risk?
So just in populations who have rotator cuff tears compared to those who don't, there's a higher rate of vitamin D deficiency. And as we know, vitamin D deficiencies, the rate's about 1 in 3 in North America, especially as you get above, as you get into higher latitudes. So it's really important. So I'm a big advocate of, essentially all women over the age of 40 supplementing with vitamin D, at the very least having a vitamin D level checked. So I would have to put that on there, including scapular exercises into your exercise regime, as we talked about. And strength training, because strength training is going to help with your shoulders in general. And it's going to help you offset in the case if you have a rotator cuff tear. It's going to put you in a better position if you did run into any issues and did need anything surgically in that case. And there's so many benefits in terms of overall mortality reduction, glucose improvement, and mood improvement that strength improvement is really, really important.
You're speaking my tagline. I'll have to send you a check in the mail.
Yeah, no, it's real though. I know. I'm a big believer. I'm a big believer in this. And when I see the people who are not doing that, that's the one where it's really it's a syndrome where they are elderly, they have poor bone density, they have poor mood, they often have poor nutrition. It all goes together.
It snowballs fast. Yeah.
It does.
Yeah, my mom was
so.
in the hospital just recently, and I flew in to take care of her. And I don't know how many people were in the unit that we were in, but as soon as I saw her, and I could see the disheveled state she was in, she'd already been in the hospital for several days. And I just, let's get you showered up. Can you walk? Let's get a walking routine down. And then in a couple of days, it was like, can you do some squats? So we did some body weight squats. She was holding on to the little, like a little emergency bed in the hallway. And I think we were the only ones. I didn't see that the showers, we used a shower, and then we went back the next day, and I said, oh my God, I'm sure everything is exactly how we left it. I don't think anyone's using the shower. And,
wow.
All of those things, like the movement, and just, I think when you're an athlete, you understand the importance of that routine, and you understand that you do something not because you want to really do it. You might want to just lie down and be in bed, but you should do it for the long-term pleasure that you're going to get. And that's a real important piece of that puzzle, the why we do all these things. Stuff catches up, and you want to be as prepared as you can for the inevitability of age and its realities. So being proactive is so key. Thank you so much for being on the podcast. And, again, my mom had just such a wonderful outcome. And one of the reasons why I chose you, number one, I found you on Instagram, and you were training and talking about the importance of building muscle. And I tell it to my clients, go work with somebody who trains themselves and understands the importance of nutrition and training. That's the first thing. The second thing is you contribute so much to that space. You do a ton of surgeries. I think you told me you do 300 shoulder surgeries a year, and your surgeries, mom's shoulder was in replacements.
I do 800 surgeries a year.
800?
300 of those.
Oh my God. Okay.
Yeah.
800 surgeries, 300.
800, and replacements are 300 of those, but it's a lot. Yeah.
So you're pretty niche down.
Pretty niche, and fortunately I love it. But I also get just focus on all the little details that go into it, like you're saying, right?
The size of the prosthetic, you wanted us to do another round of imaging so you could really get grainy with the size of the prosthetic. That was important to you. The antibiotic and drug protocol was unique. I was expecting, 10 vials of medicine, but you told me you did a little bit of antibiotics in the IV. And then post-op, it's as needed, and mom didn't need any antibiotics. Is that correct?
Yeah, that's right. Just prior, we take a lot of steps to prevent, and 30% of my patients don't take a single narcotic. Having a good approach, having a good system to it.
I know my mom doesn't like to take narcotics, and we found out now that for older people, seniors, there's that increased risk of pretty significant GI issues with even one pill of an opioid can be problematic, and then compound that with a slew of antibiotics can really get things knotted up. So I'm going to share, guys, listening, please, I hope you listened with an open mind. If you're scared about surgery, please don't be. And it's not about pushing surgery, but being very evidence-based, data-driven, whether you're a candidate. And there's steps to take to investigate that. I'm going to share Patrick's Instagram and the website, the Oregon Shoulder Institute, with you, where he works out of. And I encourage everyone to do your research. That is where true choice, empowered choice comes into play.